Good evening, everyone. I'm Mike Barrett. Welcome to our second in a series of sessions on the Grey-Bruce health system. I'll just give it another 30 seconds or here or so, let people join in, and then we'll get things started. I'll give an overview of what we plan to accomplish tonight, and then provide an opportunity for you to have any of your questions answered as well. But we'll just give it another 30 seconds. Good evening, everyone. My name is Mike Barrett. I'm the president and CEO of South Bruce Grey Health Center, the four-site hospital in Gardner, Walkerton, Chesley, and Durham. I also have the privilege of being the co-chair of the Grey-Bruce Ontario Health Team. And that's the setting in which we're gathering tonight. If you were part of our session back in June, we felt it was important to bring anyone who's interested across Grey-Bruce or outside Grey-Bruce with an update on what the health system looks like here in our two counties. Back in June, we had a presentation from three sectors. We had the hospital sector, home care, and long-term care, where different speakers brought updates on what those sectors look like in Grey-Bruce, with the opportunity for the public to ask any questions. And tonight is our second in the series, and tonight we're going to hear from home and community support services. Community support services, primary care, and mental health and addictions. And we'll do the introduction of the speakers in just as we go through the presentation tonight. Where we're going to start is a quick overview of the Ontario Health Team, what that is, what it means to you. But tonight is really about providing an opportunity for you to learn more about the health system here in Grey-Bruce. So we've got a number of slides we'll bring up, and those slides will provide that overview of not only the OHT session, but also the session on each of the three different sectors. So just go to the next slide, please. So just some important points here around the how we will run the session tonight. Hopefully some of you or all of you have had the opportunity to use Zoom. Over these last 20 months of the pandemic, Zoom has become almost a daily fact of life in many people's lives. But if you're not familiar with Zoom, take your mouse and hover over the bottom of the black screen. There you'll find a number of different commands. So the mute button, participants, chat, and if we'd ask all of you to mute your microphone so that we don't have any background noise. So that's the icon on the very left side of that bar at the bottom. If you're joining us by phone, use your *6 number on your phone to mute and unmute your microphone. If you want to connect by video, click Start Video, which is the second icon in from the left. And then the chat feature, and that's probably the most important one for tonight. If you've got questions that you want to ask the group as they're going through their presentations, click on that chat box, type in your question and type it to everyone so that everyone can see your questions. And then whoever is speaking or whoever the question is directed to, we can make sure that it's that person has the opportunity to answer those questions. So the agenda for tonight, I've kind of covered this already. We're going to do a land acknowledgement, a welcome and introduction of some of the speakers, the purpose of the information series. We'll talk about those three sectors, which I mentioned already. And then as I've said a couple times, this is about getting information to you, but also answering any of your questions that you may have about the health system here in Grey-Bruce. So I'd like to start tonight's meeting with a land acknowledgement. I really want to start the meeting in a good way by acknowledging the Indigenous peoples whose traditional territory we've gathered on today. I wish to acknowledge the long history of First Nations here in Ontario and show respect to them today, especially a day in advance of the National Day on Truth and Reconciliation, and want to recognize the two First Nation communities here in Grey-Bruce, Chippewas of Nawash and Ceded First Nation, and then Saugeen First Nation. I'd like to just acknowledge a few people who've been actively involved in the development of the OHT, the Ontario Health Team. So myself, and I have the pleasure of co-chairing it with Alex Hector. Alex is the Executive Director of the Southeast Grey Community Health Center. You're going to hear from Alex tonight. And I won't go through the list here, but these engagement subcommittee members have been very active in advancing the work of the OHT here in Grey-Bruce. From all different sectors, primary care, long-term care, mental health and addictions, hospital. And all of these folks have day jobs. So they have responsibilities within their own organizations. You can see the organizations listed there. But in addition to that, everyone is contributing to the OHT. And I'll talk about what the OHT is when we bring up those slides. So I've talked about the purpose of tonight. I won't repeat that again. The Ontario Health Team is, if you look at how health systems are structured in Ontario, across Canada, around the world, they're always changing. And you look at any of the provinces across Canada, they change on a fairly frequent basis, depending on the government, depending on the directions of the government that's in power at the time. And for example, in Ontario, we had regional offices of the Ministry of Health. We had 7 regional offices. Then we had LINs, local health integration networks, 14 of them across the province. And the latest legislation to come out is really important for us in Grey-Bruce because it allows for the creation of the Ontario Health Team. The Ontario Health Team is really intended to bring partners together across the geography. You'll probably say, well, aren't partners working together already? And yes, they are. But this really provides an emphasis to that. The most important point for the OHT, I'd say, for Grey-Bruce is that it allows us to create our own future. And not saying we're going to do anything outside of provincial legislation or provincial direction, but allows us to create a health system that'll work for the people of Grey-Bruce, the geography of Grey-Bruce, how we're structured. It allows us to create a system that will best meet the needs of the patients, clients, and residents we serve. It's probably hard to see this slide. These slides will be available after the session, but if you look at the 2 bottom diagrams with the colored circles, in the middle of that circle is the patient, client, the resident. And right now that patient is interacting with different, may interact with the hospital and may interact with long-term care or primary care, their family physician, community mental health and addictions, all kind of separate. The purpose of the OHT is to bring all those providers together under one umbrella and working closely to make sure that the patient, client, resident is cared for properly. And a message that I deliver quite frequently is that when we do satisfaction surveys, whether it's in hospital or long-term care, it's very, very frequent that people are giving high satisfaction rates to their care within a hospital or with their family physician or long-term care. Where they have frustrations, where the public has frustrations, is in those handoffs between providers. So that's what the Ontario Health Team is supposed to do, is to ensure that those connections are better connected for you as a patient, client, or resident. So the good thing is that our application for an Ontario Health Team was just approved. So we've been working towards that for the last 2 years. On September the 17th, Minister of Health Christine Elliott announced that our OHT, along with a number of others across the province, was officially approved. So this is good. It means that we'll have access to some more funding from the government. So very appreciative of the $1.1 million that will be coming from the government of Ontario, which is great. And it'll allow us to actually have some staff to do some of this work. Right now, our Ontario Health Team has 2 staff members, Jen Kehoe and Abigail Woodcock. But there's a lot of work to do that requires some folks to be able to deliver on that. So this additional funding from the government will allow us to do that, and then allow the partners, as I've said a number of times, to work more closely together. If you're interested, the news release is there, and you can see some better descriptions of what an OHT does. The OHT in Grey-Bruce right now, we've got a number of different groups that are providing advice to make sure we're making good decisions, good, strong decisions to improve the healthcare system here in Grey-Bruce. The planning committee is the main oversight committee. We're calling it the partnership table. We have an engagement subcommittee, which was the membership I showed you earlier. We have a physician and nurse practitioner council composed of physicians and nurse practitioners to give advice to the OHT. This is really important. Physicians, nurse practitioners, very busy people, and we need to ensure that those voices of those physicians and nurse practitioners are brought into the OHT. So that's group has been established and is providing lots of good advice already. We're establishing a chairs council, which is made up of board members from different health service providers. So we had our first meeting of that group yesterday to develop terms of reference. And then the final one is the community council. And the community council is composed of 12 patients, clients, and residents from across Grey-Bruce. We had an open call for people to sit on that group. We had a large interest. About 200 people applied. Ultimately, we interviewed 25 people, narrowed it down to 10. We have 10 that have been appointed now to the community council, and they'll provide that patient, client, resident voice to the OHT. And the final two will be patient, clients, and residents from the two First Nations that I mentioned, Nawash and Songhees. We've identified two priorities for our OHT. The first is frail seniors with a focus on transitions in care. So how do they move through the system? And maybe I'll translate that a bit. So you've got a mother or father, frail senior, going to their primary care physician, needing additional supports, may have a fall, end up in the emergency department, and then needs to transition to another setting, whether it's home care at home or long-term care. Our focus is to smooth that transition for those frail seniors. And then the second focus for our OHT in year one is patients and clients living with mental health and addiction issues. And you're going to hear from Clark and Phil tonight about some of the overview of the system and what it looks like here in Grey-Bruce. And finally, just before I pass it over to the presenters tonight, this is an overview of the funding that comes into Grey-Bruce. So again, this is money coming from the government of Ontario. So thank you to the government for that. $361 million a year comes to Grey-Bruce for healthcare. That includes $193 million to hospital services, the 3 hospital corporations. Long-term care is just over $70 million. I won't go through the rest of the list, but you can see it's a considerable amount of funding that's coming in to ensure that we have high quality healthcare here in Grey-Bruce. So at this stage, I'm going to pass it over to our first presenters for tonight. Steph Dungeon is not able to join us. He was going to be coordinating the presentation for the 3 speakers. But I'm going to pass it over to Alex Hector, who I said is our co-chair of our Ontario Health Team here in Grey-Bruce, and he's going to lead us through the next steps here in the presentation tonight.
Great, thanks very much, Mike. Yeah, I really appreciate it. And good evening, everybody. Thank you for your time and your interest in what our health system in Grey-Bruce is all about. And I am kind of pinch hitting here. Steph, unfortunately, is ill, and just at the last minute, I got asked if I could step in her shoes, and they're big shoes to fill. So I'll do the best I can this evening. Next slide, please, Jen. And Dr. Savaria, please don't hesitate to weigh in. I think between you and Steph, there had been a number of slides, and I don't want to take over the ones that you were designated to do. And actually, I just got a little note here from Jen. You're doing the first 3, so I'll turn it right over to you. Thank you.
Okay. Hi, everyone. I'm Elise Savaria. I've been a family physician in Grey-Bruce for 30 years, started in Durham, and as a new grad for 7 years, and the reminder and Owen Sound. So I'm part of the physician and NP primary care and specialist council. And I just want to talk to you about primary healthcare in Grey-Bruce. So as we know, primary care will address the majority of a person's health needs through their lifetime. That includes the physical, mental, and social well-being. Also includes the illness prevention, health promotion, diagnosis, treatment, rehab, and counseling. Primary care health approach will include 3 components: meeting people's health needs through their lives, addressing their broader determinants of health, empowering individuals, families, and communities to take charge of their own health. Next slide, please. So if we look at the primary care payment models, there's been a lot of changes over the last probably 15 years, I would say. It used to be that people would be paid in a fee-for-service model. So if you saw 20 people in a day, then you would be paid for seeing those 20 people. Now, it's a bit more complex. There is a group-based practices, family health team, and family health organization where people can be part of and will be paid then based on a roster size. So if you have 1,500 patients, you will get a certain amount of money per year based on age and complexity of the patients. You can still also bill a portion of this fee for service, but it's a minimal part of this. The other types of salary is another option depending on the type of work you're doing, and you can have a bit of a blended model. This is to address obviously the needs of the population, and it is in support of also team approach, and we can discuss it a bit further. Next slide. So I mentioned earlier the family health team. So some groups of physicians are part of either family health organization and work in cooperation with teams made of other professionals to offer different programs. So the type of professionals that you can actually work with would be registered nurses, social workers, occupational therapists, kinesiologists, respiratory therapists, chiropractors, dietitian, pharmacist as well. And through this work, you can also then create programs that can address specific needs, like have counseling, smoking cessation, diabetes management, respiratory health, prenatal and postpartum health, rehabilitation, mobility maintenance and recovery, geriatric support, nutrition counseling. And I'm probably forgetting some, to be honest. Next slide. So in Grey-Bruce, we have a lot of this type of primary care team-based, Brockton, Hanover, Kincardine, Owen Sound, the Peninsula, Sauble, Southeast Grey Community Health Center, Southwest Ontario Aboriginal Health Access Center in Owen Sound. Next slide. Alex, did you want to talk about it? Or do you want me to keep going?
Totally up to you, Elise. I'm if you want to roll with it, I'm good.
Sure, I can do it. So primary care access, if we look at the percentage based on the data from 2016 to 2018, 95.7% of the population has a primary care attachment, can be a nurse practitioner or a family physician. So there's some data about estimated percentage of primary care unmet needs, estimated needed visits less actual GP visits of 15.7. I'm not sure that I can, 2 seconds. Okay, 67.2% percentage patient went to the emergency for something that could have been treated by a primary care provider as well. And obviously, in addition to having practices, family physician, and NP are involved also in other areas like long-term care, hospital system, emergency room, obstetrics, inpatient care, surgical procedure, anesthesia. Palliative care is another one that is not mentioned there, but I think it's a big one. Next slide. So what are the challenges? It's very difficult still in 2021 to recruit. Grey-Bruce across is underserviced, meaning that we have over average population numbers per physician. So I think in Ontario, the acceptable or normal average number of patients per practitioner would be around 1,400. And across the area, there's quite a few physicians that have a lot more than this, on top of having, other responsibilities. So challenges about health, human resources, equitable access to team-based care. So you may have some physicians that are still working individually, like in a non-team approach, and the government has restricted the number of physicians that can actually join in a family health team. At this point, we can often replace physicians that are retiring, but we cannot actually add on. So there's some restriction that are actually done at the ministry level. So there's opportunities to obviously better align different resources across all the different agencies and have a more systematic approach to delivery of primary care. So this is quite exciting. Next slide. Oh, sorry.
Yeah, that's okay, Elise. Thank you so much. I think you're done. Great job, and I appreciate you going all the way through. That's I'm a lot less nervous now. So thank you. Before we go further, I just want to take a moment and acknowledge and introduce Bill Walker, our MPP. Bill is a very active proponent of all the health service organizations throughout Grey, and I just want to thank Bill. I know you're a really busy guy, and really appreciate you taking the time tonight to attend our session. And again, thank you for your ongoing support to all our organizations. It really is important, and you do just an absolutely great job for all of us. So thank you very much for that.
Thank you very much, Alex. My pleasure, and always here to help.
Absolutely, absolutely. And maybe one day I'll get a lesson in auctioneering, and then I can make these meetings go even quicker.
Happy to do so.
Absolutely. So our next speaker is my colleague Steve Musehl, who is the Executive Director of Home and Community Support Services, and he's going to talk to the Community Support Services sector. So over to you, Steve.
Thanks, Alex. I did notice there's a question in the chat. Did you want to do all that at the end, or do you want to take them now?
Thanks, Steve. That's a good point. I think what we'll do is save the questions until the end, and that way we can make sure that everybody we can get through all the material, and then any questions that we can't address at the end, we'll address via email out to all the attendees after that. Hopefully that's okay with everybody. Thank you.
Thanks. So yeah, as Alex said, my name's Steve Musehl, and I work for Home and Community Support Services, representing the community support services sector today, which is Alzheimer's Society, Grey-Bruce, Dale Brain Injury, HCSS, Participation Lodge, Grey-Bruce, Southwest Ontario Aboriginal Health Access Centre is also a CSS funded agency, and the VON, or Victoria Order of Nurses, Grey-Bruce site. So community support services, we focus on promoting independent living, prevention, early intervention, self-management, health and well-being, such as nutrition, health and wellness, personal, social, and palliative supports for older adults, persons with disabilities, brain injury, and/or dementia. We have a lot of benefits. A lot of our focus really is both in keeping people, out of hospital and out of long-term care in their homes, as well as helping people return if they have had an episode where they need to go to hospital for a while and they need to help recover. So we really do focus on the quadruple aim that I think Mike spoke about a little bit earlier in Ontario Health Teams, right? Providing that improved experience of care, improved population health, that early intervention of before you need serious health care. Let's try to keep everyone healthy. And then of course we pride ourselves at our improving value for money. Again, keeping people living at home in their communities as long as possible. We are very cost efficient and an alternative to institutionalization. More and more people as they age, and Grey-Bruce of course is a older population. The focus really is to live well at home. Our long-term care partners do an excellent job of their services, but people want to live in their homes as long as possible for the most part. And we do provide a lot of support to our partners here. We work well. We're in primary care and memory clinics. We help in hospital discharges and free up beds in hospital long-term care so they can do what they do best. Slide, please. So the types of services offered, and you can't see this, I'm sure, from your computers, but as I said, this will be going out. And some of the things we do in Grey-Bruce really well. We have an adult day program and an overnight respite program for people. So we provide over 22,000 client days of day program, which is about 150,000 hours respite and 500 overnight programs. We have 120 assisted living beds, including 6 locations and 33,000 hours of assisted living. Clinical support, like I mentioned, we're involved in care planning, assessments, memory clinics, education and support. So we have dementia-specific caregiver support groups, bereavement supports, health and wellness. We have the Smart Exercise Program, Minds in Motion, social recreation, Meals on Wheels and nutrition. We were almost 100,000 meals, hot and frozen, served throughout Grey-Bruce last year through the Meals on Wheels program. Safety checks. You may have heard of the Kool-Aid program, which is just another way to have a safety check for people in their homes. Telephone reassurance, virtual visiting, in-home recreation visiting. And then we do supports in the home as well. We have friendly visiting programs, in-home recreation, hospice volunteer visiting, family dementia counseling, Home at Last, which is hospital home support, housekeeping services, community bathing program, and more. So really we touch on a lot of different things, and all of it's try to provide people stay in their homes. And during COVID, we've done a few things different, as everyone has during this last quick 20 months. But a few things we're really proud about. We developed a bundled care program to help our hospital partners on discharges, make sure people don't return back to the hospital after their discharge. So with that, we actually reduced the readmission rate quite a bit. Our day away programs and the Alzheimer's Society recreation program went virtual to provide a lot of virtual programs. We started in-home respite at the same time, recreation, education, outdoor socially distanced programs, expanded food security programs and hamper and personal supply delivery. And we have what's called a community support service flex fund and respite fund. So we actually were able to help over 100 families in emergencies last year, whether that was emergency respite, emergency equipment, renovations to their home, things that they didn't have, they would have been either to the hospital or to long-term care. We provide them some funding or some support so they're then able to stay in their homes. So our strengths, we think, the big thing that we really try to do is reduce that unnecessary institutionalization. Early intervention, get in the homes early, and the intensive support programs. So, they're, as I said earlier, long-term care and hospitals, of course, do an amazing job at what they do, but we try to get people to be able to live in their communities, in their homes as long as possible. We have a lot of programs that are focused on reducing ALC rates, letting people either live in their homes longer so they don't end up in ALC, or if they are in ALC, to help them transition out. And our value and cost efficiency. For every dollar of Ministry of Health and Long-Term Care funding, we have about $1.14 in value. Home and Community Support Services, the agency I work for, example, has about 700 volunteers that did over 100,000 hours before COVID-19 hit. So, you know, even at minimum wage, we're looking at $1.4 million of value just from volunteer hours there. And then, of course, the community is amazing for all of our programs. So really, with that support of volunteers and donations, we're able to really expand and stretch what we do. And we're also really proud, as Michael said, the quality of care we have. You know, people are very happy with the services we provide. It's really focusing on working better in between different sectors. Next slide, please. So challenges and opportunities, and I'm sure you'll hear these two over and over again. Funding for us, you know, we've slipped under the funding radar a few times, and in the last 11 years, we've actually had a 3% increase. In the same 11 years, it's been an 18% inflation. So it's really hurt our, you know, the erosion of salaries, the quality of the programs. The base funding just hasn't been able to keep up with inflation, and, you know, things such as IT security and many of these things that have come in over the last 11 years that have really increased costs, and we've been looking for other places to find them. Awareness, I don't know how often I hear, both with HCSS, the Alzheimer's Society, etc. People always say, I wish I knew about your services earlier. I wish I knew about that when my mom needed them. So we are trying to do more and more awareness so people know of the supports that are in the community for them. Right now, you know, there's a bigger crisis in the community, I think, than ever before. People are waiting longer to go see their family physician, waiting longer to go to the hospital. So there really is a crisis in the community. There's, you know, growing wait lists for long-term care. People are more and more worn down. Caregivers are exhausted living in the, you know, supporting their loved ones in the community without help. So really, you know, there is a crisis in the community, and I want to make sure people know that. And as everyone else will say, certainly health, human resources, there's a large shortage of PSWs, nursing, social work. You know, it's just the lack of availability of healthcare staff and other staff is challenging for all of us. And it seems if one of us hire, it's at the cost of another agency. So really need to focus on that. Our opportunities, we do have, you know, some really good things that happened during COVID-19 that we can expand on. We have some more room for some of our programs, such as adult day program, overnight respite, assisted living, counseling. We can ramp those up very quickly. As I mentioned in the previous slide, we have a value for money. A lot of our programs very cost efficient, and the volunteer hours, well over 100,000 volunteer hours in CSS across Grey-Bruce, really incorporates the community into the care. And we are working super close. If you saw our June presentation, Home and Community Care Support Services, which sounds very similar, presented. Their home care and CSS are different. You know, that often confuses so many people in healthcare and out of healthcare. So we have to be able to work better together with home care so that CSS and home care, you know, is that under that umbrella of one service and one type. So really looking forward to continue our partnership with them. And just a little last slide of, you know, what if CSS didn't exist? You know, then there'd be longer hospital stays because there wouldn't be support when you leave. Increased pressure on the healthcare system. The hallway healthcare issue would only increase. Increased caregiver financial burden because it would be a lot of private services, and a higher unemployment rate because the pressure on caregivers to, you know, not work when looking after a loved one. So, you know, we're very, very proud of what we do in the community, as everyone here is. So I think that's it for me, and I'm going to now pass it off, I believe, to mental health addictions Clark.
Thanks, Stephen. My name is Clark MacFarlane. I'm the CEO of the Canadian Mental Health Association, Grey-Bruce Mental Health and Addiction Services. And within Grey-Bruce, we have three main mental health and addiction providers, CMHA, Keystone Child and Youth Found Services, and Grey-Bruce Health Services. Could I have the next slide? In terms of what we do in the mental health and addiction sector is essentially provide supports and services to those living with mental health and addiction issues. So we support them to live in the community and help them in times of crisis when they need some assistance in stabilizing. So broadly speaking, we have both an adult stream and a children's stream, and we have community-based services and hospital-based services. So in the adult stream, both Canadian Mental Health Association provides both mental health and addiction community-based services, as does Grey-Bruce Health Services, has some community-based services, and our hospital-based services, or what you might here referred to as their Schedule 1 facility, is with Grey-Bruce Health Services at the Owen Sound site. On the children's stream, we have on the community end Keystone Child and Family Services that provides services, mental health services to child and family, and Grey-Bruce Health Services has pediatric beds as well and provides services. So next slide. And I'll hand it off to Phil to describe Keystone's services offered.
Good evening, everyone. I'm Phil Dodd. I'm the Executive Director of Keystone Child, Youth and Family Services for Grey and Bruce County. So just quickly going through the provision of services that we offer at Keystone, and we're focusing only on about half of our organization, which is our mental health side, for the purpose of this presentation tonight. So our budget's about $4 million, equating to about 35 clinical staff, which includes 10 staff who work in our live-in treatment program. So we have a quick response clinic, which is a brief service model. We have our long-term counseling service. We have an urgent emergency response team providing risk assessments to young people and their families struggling with suicide and depression. We have our intensive supports, which includes our live-in treatment program, which is a 7-bed co-ed live-in facility located currently in Owen Sound, and the age range there are 12 to 17 year olds who would come in for crisis assessment, stabilization. Typical stay in our live-in treatment is about 3 to 6 weeks. We have a partnership with Grey-Bruce Health Services and are involved with the adolescent mental health unit up on the hospital in Owen Sound. We have a system navigator position that is positioned in the Owen Sound Hospital, attached to the crisis team working group up there, and they're servicing all 11 emergency departments in Grey and Bruce County to ensure that if a young person ends up in an emergency room, we can seamlessly shift them into Keystone counselor assessment in a timely manner to avoid them spending any longer than they have to in an emergency room. We have a Section 23 classroom. Section 23 of the Education Act is where that name comes from, and it's attached to our live-in treatment program, and it's a partnership with the Blue Water District School Board. We have access to psychiatric and telepsychiatric assessments, and in partnership with the Grey-Bruce Health Services on those. And we have a myriad of educational and parenting workshops, and our website is always full of those opportunities if people wanted to look. And then we also provide court support for the youth mental health diversion, and we also provide what are called Section 34 mental health assessments for young offenders who the court is asking for an assessment prior to their sentencing. So that's just a quick overview of the mental health services that Keystone provides. And I'm going to pass it on, I believe, to Naomi.
Hello, I'm Naomi Vauden. I'm the Director of Mental Health and Addictions at Grey-Bruce Health Services. We have a wide variety of inpatient and outpatient programs for both mental health and addictions. We're funded a model where we have community funding as well as hospital funding. We have inpatient beds for both the geriatric and adult population, and as well, we have a psychiatric intensive care unit. And then, as Phil mentioned, we have the 2 pediatric mental health beds that are on our women and child unit and supported by Keystone staff. We have beds at our withdrawal management, and so we have a detox service as well as a 3-week community addiction treatment program. This is an outpatient program, but if for people that live outside of Grey-Bruce, they are able to stay there for the night. We provide crisis support to patients attending the Owen Sound Emergency Department, and as well, we liaise with the CMHA MHeart team to facilitate psychiatric assessments at the other hospital sites in Grey-Bruce and arrange transfers to the mental health unit at Owen Sound Hospital if needed. As well, we have a sexual assault and partner abuse care team, and we provide 24/7 care to all incidents of sexual assault that arrive in the emergency department. We provide the services of the sexual assault nurse examiner, who provides emotional and physical support to the victim of the assault and also collects forensic evidence. Ongoing counseling is also provided to victims of both domestic abuse and sexual assault within Grey-Bruce. Just outside of our ED, we have a bit of a crisis support program, and that's fairly new, where you can go once you've been cleared from the emerge, and you can sit in there and receive a little more focused mental health care and a little bit more calming rather than an emerge department environment. Let's see, we have RAM clinics throughout Grey-Bruce, so that's rapid access addiction medicine clinics. And we've got quite a widespread, but we're still planning more spreads, so more to come there. And as well, we have substance use counselors and clinical nurse specialists that provide addiction and mental health support to the hospitals and into the non-mental health units. We have a wide variety of outpatient programs, including case management, counseling, and a specialized first episode psychosis team, as well as a dual diagnosis team that works for people with mental illness and developmental disability. As well, in Owen Sound, we have an assertive community treatment team that provides 12/7 intensive support for clients with a serious mental illness. And as well, we have a BSO team, a Behavioral Supports Ontario team, that works with the Alzheimer's Society to provide care throughout Grey-Bruce for those with a dementia diagnosis. And then finally, we offer counseling and addiction support to both Neheshiniming and Saugeen First Nations. So that's a real quick whiz through, but some of the programs are also on the slide. And now I believe it's Clark.
Yes, thanks, Naomi. So our services are really geared to supporting people in the community so they can maintain their lives within the community and engage in community activities. So on the mental health side, some of these blend over, but we have social recreation and rehabilitation programs, and these are our social rec programs are member-based. And they will run programs that they'll go camping, they'll have social events. You know, the 3 pillars of mental health are a home, a friend, a job. So the social rec really speaks to that friend piece. It helps people develop a social network and gives people a social context, and is so critical to our clients' mental health. They'll, in speaking with them, they'll say, you know, the community I have through social rec is just as important as the counseling I receive. It helps me either stay sober or stay balanced as well. We have an ID clinic. Many of our clients don't have any type of ID, so they may not have a health card. They may not have a birth certificate, which really makes it difficult to engage in other services if you don't have that ID. So we help them navigate that process, which is can be quite a daunting process for some of our clients. So we support them through that and help them get plugged back in. We have peer support services, which both for families and for individuals. And a peer, when we use peer, is someone who has lived experience with a mental illness and has some training in how to use their story of recovery to support and help others who are going through the system as well. Housing and support services, we have rent supplements, as well as we own a sixplex apartment building, as well as 2 residential homes, one in Wyerton, one in Owen Sound. And that is, yeah, a very busy program. Housing is a very intense need at this point in time. We also have court support for both addiction and mental health. So individuals who bump up against the justice system are provided with an opportunity for diversion and to go through some support and treatment and avoid the court process. We also have intensive case management, where case managers will help people find housing, get connected with other services, and support them with what they need to live in the community. We also have primary care funding. We have funding for a nurse practitioner. We have found it best to contract that out, and we have partnered with Brockton Family Health Team. So we flow the money to them, and they hire and support that nurse practitioner. And that nurse practitioner is dedicated to providing primary care for individuals who live with mental health and addiction issues. So that's a really important program, in that often people living with serious mental illness or significant substance use are not the most popular folks to take on as patients, and they have a fairly heavy burden of care as well, because they have a lot of comorbidities and may not have seen primary care. So it is a fairly intensive caseload there. And as Naomi had mentioned, we have the mental MHEART, or the Mobile Mental Health and Addiction Response Team, formerly called URT, Urgent Response Team. And this program is only accessible to the police and EMS and emergency departments. So these workers are called out. Actually, we have them both embedded in the police stations. Every police station in Grey-Bruce except Grey-Bruce Grey OPP, when we're working on that. And also we have a regional MHEART worker that responds to the ER. So they will go out, assess situation, recommend either hospitalization at Sched 1, or we'll follow up the next day, connect them with other services. So on the youth side, I put that in because we have a program that is more a mental health promotion in the schools with Jackie Ralph. You may have heard Jackie. I think everybody in Grey-Bruce may know Jackie. And she goes into the schools and has puppet shows and teaches kids about positive mental health and how to deal with emotions and various situations. So it's a very, very popular program, and she reaches quite a vast number of kids in Grey-Bruce. On the addiction side, we have counseling, and both for alcohol and drug and gambling. We have a program, Pregnant Parenting, that focuses on young moms who are struggling with a substance use disorder and are pregnant or have young kids. And we have concurrent disorder. Concurrent disorder just means individuals living with an addiction and a mental illness. We also have peer support focused on addiction. Housing services, it's called ASH, or Addiction Supportive Housing, which have some units that or monies dedicated to support people who have significant addiction issues and are difficult to house. So we provide them that support. Court support, again, primary care, and G&B House, which is a 15-bed recovery home for men with substance use disorders, just out on 9th Avenue. And on the youth side for addiction, we have a program called Choices, and Choices, they go into the schools and deal with kids, counsel kids who may have or are at risk of. One thing I didn't mention just very quickly is we also have some social enterprises. We have a catering business. We also are about to open a cafe, and we have a garden where we employ people. And these are, we employ our clients to do work. It takes care of that other pillar, the job. It really helps provide people with purpose and a reason to get up in the morning. So, but I will now pass it along to back to you, Naomi.
Okay. I did mention earlier that we actually have become quite fortunate in building our psychiatry team. So we do have 6 adult psychiatrists, 3 part-time, 2 child and adolescents, and 2 that come a couple days a month with varying specialties. So we're very fortunate there. And all the psychiatry team is a referral from the family care provider, from the nurse practitioners. We also have a nurse practitioner at GBHS that does primary care that can also do the referral. Our crisis services are 24/7 in Grey-Bruce, and the crisis support program is open 24/7. And the inpatient beds are really, as somebody else asked about the occupancy, they're always over 100%. So we're pretty full. And so the crisis team, in consultation with MHART, who's serving the rural sites, determine who is in need of the inpatient bed first, and that's how we triage those beds. We have our withdrawal management is open 24/7. No referral is required. It's just walk in. And our community programming generally is direct referrals from the clients, family members, physicians. The geriatric team also takes referrals from long-term care, and the dual diagnosis team does take referrals as well from any of the developmental services sector. And then we also have walk-in clinics throughout Grey-Bruce where we have posters throughout Grey-Bruce that tells you when and where to be, and you can just walk in and see someone there. So I think it's next would be, I think, Phil.
Yeah. Thanks, Naomi. So in terms of access to Keystone, if someone wants access to any of the services that we offer, it's a simple phone call from the family to our intake department. And our phone number is on our website, and it's here on this slide. We do accept referrals from physicians and school boards and probation officers and the like, but we are a voluntary counseling service. So the family will have to voluntarily engage with us. So if someone calls on behalf of a family, we would then contact the family and follow through with our intake process. So it's pretty straightforward in contacting Keystone. And Clark, I guess back to you.
Yes. So essentially, for pretty much all of our programs, it's either self-referral or referral from another agency, with the exception of MHART, which can only be accessed by police, as I had mentioned, EMS, or emergency department. So that number is not released to the public. Otherwise, it is self-referral. And for our social rec programs, it's the intake is pretty light. It's self-identification. Anybody who wants to really participate can. Like Keystone, they're voluntary, so people can choose to come and go as they wish. Really, the only forced service, I guess, in mental health is really the SCED 1, where people can be formed and taken to the hospital against their will, really. So that's about it. And I think I can't remember who's taking this one. It's the opportunities with
I don't mind jumping in, Clark, if you want.
Okay, very good, thanks.
I know Naomi's going to take the challenges. So with respect to opportunities in the sector, I think we talked a lot as a group of us around the stronger partnerships across all the service providers within the sector, and including all of the serving organizations that we have in education and health across the board. Also looking at an investment in our children and our youth will lessen the burden in the adult system. So I think there's opportunities there to build in developing the opportunities that we have with our young people, building better futures. Early intervention and prevention to support better outcomes later in life is the same concept. I think a key point here is that we all recognize there's an increased capacity need for personality disorders across the lifespan. So in the youth sector, the adult sector, personality disorders is a choke point for a lot of our services that we offer in mental health. Family youth engagement, family-centered care are all key opportunities that we see. And particularly within the adult mental health system, a centralized intake to allow for no duplication of service and moving people through the system and getting to the right spot as quickly as possible is an opportunity that we have moving forward. Now I think Naomi's going to struggle with the challenges.
Yes, and there's challenges. According to the Center for Addiction and Mental Health, mental illness accounts for about 10% of the burden of disease in Ontario, and yet it receives just 7% of healthcare dollars. Relative to this burden, mental health care in Ontario is underfunded by about $1.5 billion. When compared to other OECD counterparts, Canada is well behind other countries that spend 10 to 11% of their healthcare budgets. And in Grey-Bruce, we're such a wide geography. I can tell you that while our services are very high quality, we have them very sparsely allocated throughout Grey-Bruce. COVID has exacerbated both the acuity and extent of mental health concerns. Our staff are very skilled, and we've done, I think, on our sector, a very good job of coordinating around training. In fact, one trainer that came and spoke to us on actually the dialectical behavioral therapy said she really thought the Grey-Bruce had the best trained DBT staff in Ontario that she had seen. So that's the good news, but the bad news is that as Stephen mentioned, we're certainly really struggling with lots of vacancies. We're nursing, social work staff, as also I think Stephen said, we kind of pass them from one to another, and that's great to keep them in our area and to keep good skilled staff here. But we our staff are getting tired. They're all working very hard. Transferring a complex patient to a tertiary hospital is very challenging, and particularly with our pediatric patients, hardly ever happens. And as somebody noted in the notes, it's very few beds, especially 2 pediatric beds, and not getting them to London means that kids are waiting in the emerge department, which is not good for them or for the families. Housing is a very serious and significant challenge. It affects the quality of our patient lives, the ability to access care. It's hard to send a worker to someone who is homeless. The inpatient units at 100% occupancy due to a large number of patients that cannot be discharged to homelessness without dangerous outcomes. Without adequate housing, there is no mental health. And then finally, a challenge that's particular to the inpatient unit is that we're becoming increasingly the default place for someone with out of control violent behaviors. These individuals with a developmental disability or autism and cannot be managed safely in the community are admitted to our unit with year-plus lengths of stay. This is, of course, causing a backlog of an acute care unit. But more importantly, an inpatient mental health unit is not designed to meet the needs of this client group. Our team works to create strong behavioral care plans within the confines of an inpatient unit, but a home and a small stable support group is what this population needs. And I think within the OHT, there's a really good opportunity to really beef up that sector a bit. That's me.
So Mike, I think you're going to take over from here.
Great, thanks, Alex, and thanks to all of our speakers tonight. Lots of good questions in the chat box, and what we're going to do, we got until 8:30, so we want to have lots of dialogue. I'm going to go through the questions that are in the chat box, and thanks to Naomi and Dr. Savaria, they've already been answering some of those questions. But I'll triage the question to the right person around the table and let them provide a bit more detail. Keep the questions coming in. We want to make sure we answer any questions that may be on your mind. And we've got, as I said, 30 minutes to do this. So I'll start with I'll go back to the top. Sabrina Saunders asks, are the 95.7% primary care attachment local doctor attachment, or does this statistic include relocated residents who have retained their doctor in the GTA due to lack of open spots locally? Elise, do you want to answer that one?
I'm actually, you know what, I'm not sure. Stephanie did the slide, so I'm not sure. Actually, that's a good question. So a lot of people that I've come across do still have family physicians still in other communities. Also, there was a question about the 95.7%. I think that's pretty high, actually. I would probably have to recheck that. And I'm sorry, because I'm not the one who prepared that slide, but that seems really high, actually. So.
Yeah.
Okay.
Maybe I can
go for it, Alex.
Yeah, I can just jump in here if that's okay. The 95.7% stat was from a 2016-18 source called Healthcare Experience, and the 87% is from a 2020 survey conducted by the Ministry of Health and Long-Term Care. So there's a disparity from a time perspective, and I think that's probably reflective in the numbers. And we'll do our research to get back to everybody in terms of, does that 95.7% reflect only local doctor attachment, or does it include relocated ones? It's a good question, and we'll get the answer to that. So hopefully that helps. Thanks.
Great, thanks, Alex. And thanks, Elise. The next question is probably for Stephen. From Suzanne, has COVID reduced in-home support and respite care significantly? And how many people are on your wait list currently?
Yes, is the short answer. It certainly has reduced that. Long-term care partners, retirement home partners used to offer a lot of weekend respite or overnight respite. Since COVID hit, that's pretty much been taken off the board. We have an overnight respite program that was shut down for probably the first 6 or 7 months of COVID, and has resumed, but with lower capacity limits. So the overnight is certainly much less around Grey-Bruce. Our adult day program, we currently have a wait list for first day of well over 200 people. That number is probably much higher than that if we're looking, so to say, but because the wait list is over 200. And then we have probably another 200 people looking for additional days, additional second or third. Best practice is kind of 3 days of day program per person. Right now, the vast majority are getting 1. The occasional crisis client has 2. Our capacity in day program is normally 20 people per site per day, 120 people a day across Grey-Bruce. Right now it's at, half that, maybe a third. So we're looking at 60 to 80 less people a day that we can serve in day program. We don't do home care per se for the PSWs and nursing in home, and I'm not sure if somebody here speak to that, but I know they've been battling health human resource shortages and wait lists on and off as well. I just can't answer the exact numbers for you.
That's great, Stephen. Thanks for that answer. Stephen Townsend has got a couple questions in the chat box, one of which is about the posting of the slide deck. So yes, the slide deck will be posted on our website, and the recording of this session that we're having tonight with all the questions and answers will be on there as well. So people will be able to see the questions and answers. And as Alex said, anything that we didn't answer tonight and some of the stat numbers we'll put as an addendum on the slide deck, so people know that answer. We'll follow up and give that answer back to you. Stephen Townsend has the next question, really good one. Given it's more expensive and less efficient to treat people in emergency departments compared to them being treated by their family physician, and there's a shortage of family physicians in Grey-Bruce, some areas more than others, what is the OHT strategy to address these issues, and is there a target time frame for addressing it? I'm not sure, Elise or Alex, do you want to tackle this one?
Lisa, go for it, Elyse. Yeah.
Yeah, I'm not sure. It's a good question. I think everyone is struggling, right? With COVID, with the restrictions and everything has not helped. The one thing though that we have noticed that there's a part of the care now that we can do virtually and by calls as well. So in a way, even COVID has created problems, but also made us realize that maybe there are other options of ways to provide care. But realistically, unless we figure out how to recruit and also retain people in our area, it's going to be an ongoing struggle. I know that there's some talk about funding for virtual emergency care. But again, it's like a Band-Aid solution. I'm not sure that I have a lot of great ideas at this point. I think, for sure it is a priority to try to recruit, but how are we going to achieve this? Different communities are doing different things. And maybe that's also part of the things that we need to look at is how can we help have a regional approach with this, right? I think that should be obviously something that needs to be discussed further, but I don't have any great suggestion at this point. I'm not sure, Alex, if you have anything else to add.
Sure, if I could just weigh in, and thanks, Elyse, really appreciate that. And Clark, I'll just be real quick because I know you got your hand up. Absolutely, that question really exemplifies why we have the OHT initiative. And what we do have to recognize is that our OHT is only about a week old. And so we've got a week old with only 2 resources. We've got a lot of work ahead of ourselves to develop strategies to address these very, very pressing issues. And there are a variety of ways that we can tackle it. And as Elise mentioned, perhaps looking at a regional approach rather than a municipal approach. There's perhaps opportunities to engage with municipal politicians to assist with lobbying efforts through their various associations. There's a multitude of ways of addressing it. But what's really important for us to do as an OHT is to get our organization set, our structure in place, and then establish what our priorities are.
Looks like we might have lost Alex there. He was on a good roll. I'll pass it over to Clark. Clark, you got your hand up.
Sure, thank you. Yeah, I think that question sort of has a short, medium, and long-term answer as well. And I think in the long term, I see the OHT as hopefully having a significant impact on it, in that the OHT in part wants to engage all residents in their healthcare and in their healthcare system. So ideally, if everybody is engaged in taking care of their health, we can divert more people from acute care simply by avoiding conditions, by taking better steps in maintaining our health. So certainly in the long term, I think that's what we're hoping to do. I think the system itself has been trying to shift away from acute care and toward more chronic care management and prevention. And that is a huge shift to turn around, because there's a lot of behavior, ingrained behavior in every one of us, in terms of, if I'm sick, I'm going to go to the emergency. It's just sort of a reflex reaction. So over time, I hope the OHT can engage all the residents in Grey-Bruce, have the conversation around healthcare and what's important to them and how we can make it a better system and engage everybody in that too. So, which will help, I think.
Great, thanks, Clark. And Alex, you froze there. So anything you wanted to add that we didn't catch at the end?
No, I think, no, Clark did a great job. Thanks for pitching in there. Appreciate it.
Okay, thanks, Alex. And maybe I'll just ask, Dave Bradley asked a question, what is it, the provider shortage for primary care, is it anything to do with restrictions on family health teams? Anyone want to tackle that one?
Well, there's possibly a bit of this, right? But the problem is ultimately, if, there's a two-part to it. If people are not coming to this area and not aware of this area, how can we recruit, right? Everyone is looking. So the shortage is not just across Grey-Bruce, right? So, but the others, side to it is also training. One of the success story that we have in Owen Sound in Hanover as well is the fact that we've been running a residency program, us in Owen Sound attached to McMaster and Hanover attached to Western, and it has been a great recruitment tool. And I think, it's one way of doing this. There's some areas that also are trying to attract physicians with money incentives, and it works sometimes, but I don't think it's the only answer. We've tried different things over the years. The ministry, what they've done is they've restricted the number of physicians joining in into family health team. It is a problem because the younger physicians that are coming out want to work in a team approach. And because of that restriction, then they have to go to communities that are either replacing physicians or accepting. And it's not always the case. I think Owen Sound, we still are able to add on, but other communities cannot add on to their family health team. So it's a bit of a complex issue again, right? So.
Okay, thanks, Elise. Maybe we'll switch gears a bit and go to the mental health and addictions questions. Bill, do you want to, I see Bill Walker's got his hand up. You want to comment on this one before we switch
Yeah,
gears?
Mike, if I can just weigh in a bit, two different things. One is I think, from a government perspective, is understanding what the supply and demand is, and then going back to our systems that have been entrenched for years of allowing, and you can't tell people they can't go and take an occupation X, Y, Z. But I think as a government, we can do a better job of making sure we understand what the needs are of specialties X, Y, and Z. And we have 0 people going through, and we're still training 1,000 people of the old jobs of yesterday. And I think the other thing, and at least, you can maybe provide some either, yes, you agree, or you can disagree, but certainly the community that I know best is Wyerton. And most of the family physicians that I knew there, if you will, of the generation that served us for the last 30 years, they were carrying 3,000, 4,000 patients, and that's happening in Chesley, certainly Durham, Meaford, anecdotally that I know doctors. You lose one of those and the new docs are coming out saying, and I think you use the number of 12 to 1,400. Well, you have a doc who's serving 4,000 people who retires. You now need 4 docs, not 1 to replace that. And that's one of the pieces that people are missing. And I was on physician recruitment long before I ever get into politics. And to your exact point, some want to wave the dollar bills in front, but I've always been a believer if they'll come for money, they'll leave just as quickly. And there's always a deeper pot in the urban areas. And we certainly had some success in some cases recruiting the physician, but the spouse didn't like it or didn't have an occupation that now hopefully with some of the changes, and again, maybe in a good way, COVID has forced some of this, that with better internet, with better technology, people can work more from home, and that spouse may be able to be self-employed. So some of those things are happening, but none of them are overnight. And that's the challenge, of course, we all face. But I think it's just being understanding of some of those dynamics and variables aren't easy to change overnight. But I think we as government can do a much better job of assessing the need. We've done some good things, I think, back to kind of the PSW and local training of getting some of that training back to Georgian College. So some of our youth aren't leaving to go to the city to get their nursing training, for example. And then we can bring more of those people in certainly psychiatry and some of those other things that can be homegrown. Because I think like most things, if you have someone who's dedicated and loyal and wants to stay in the area, they are going to be here and talking in Wyerton. I know one of the, I'll say the last generation docs who retired, their daughter ended up coming back here, and she's recruited 3 of her friends from school. No physician recruitment committee, no amount of money there was going to do that. That was her personal connection. And I think that's another area we can certainly learn from.
I agree. And also the other side to it is there's more female physician. And the reality is there's maternity leave, the load, often because of, you know, being a mom and everything, the load also has changed. The newer physician, either female or male, I agree with you, are not wanting to work the same number of hours. There's a quality life balance also that is the reality, and it's not necessarily a bad thing either, right? You know, you want to have healthy physician as well, but it is a reality. Yes, we have to replace physician. Like myself, I had to have 2 physicians take over my practice recently, so it's part of the puzzle, right? So like I said, it's a complex issue.
Thanks, Bill and Elise. Some really good comments there about the challenges and opportunities for getting more primary care physicians in here. I see the our event has gone to the dogs, Sabrina. Sabrina's dog was licking her, I saw. Okay, let's switch gears to mental health and addictions. A great question from Carol Merton. Are the resources for mental health and addictions to meet the population needs anticipated to increase as a result of the impact of COVID-19? I think Naomi kind of mentioned or did mention this about resources. So Clark, Naomi, Phil, anyone want to tackle this one?
I can say I hope so. Maybe that's Phil. But I guess we can, it's hard to say. I think the government will certainly be pressed on a number of fronts for funds. I certainly hope we can. You know, as Elise had mentioned, COVID has shown us what we can do virtually as well. And so I'm hoping that we can continue to stretch our reach using technology and access that. So I can't say that we've had any promises that we will have a huge influx of resources, but yeah, hope so.
Carol, do you want to add on to that?
The question, the reason I raised the question is coming out of COVID-19, we know that we're facing, some will call it the next emergency, which is the opioid overdose and the mental health situation. So it raises a concern, and it also raises the issue of how will the health team prioritize where your focus will be and where your ask of the government. And open disclosure, I am a counselor for the city of Owen Sound. So I'm one of those government people. Small tier though, really small tier. So, you know, it raises the issue. We know there are needs out there, but coming out of COVID, we sense that there will be priority needs. How will the health team as a group start to work on where do you put your efforts and energies? How are you going to move it through? And how do you measure the deliverables? But we certainly, there's so many needs, but post-COVID, there's going to be some already urgent needs.
Yeah, I could take a stab. I think once we have the collaborative decision-making, you know, structure stood up and it's functioning, and we can actually sort of process decisions through as an OHT. In the first year, we're going to have to decide on some key projects, and I think part of the deliberation, I can assume, will be what will have the greatest impact, and what should we leverage. So, you know, there is that sort of quadrant, you know, low effort, high impact, high effort, high impact, and what do we want to do within our in what will be the current context at that time. So certainly the opioid situation is concerning. I know, we are working with counties to look at mobile options and looking into other programs that are sort of pushing the envelope in terms of safe supply and things. Maybe tangentially, a huge issue and barrier with the opioid piece is also stigma, and with addictions is stigma, and trying to shift the public understanding of substance use disorder from a moral issue to a health issue. That it is a disease that's grounded in trauma, not necessarily in choice. And really, as I think that understanding changes, there will be a greater acceptance of interventions that I think will have greater impact, and I think may give our politicians greater social license to support some things like that too. But that's sort of my 2 cents too.
Great, thanks for the question, Carol, and thanks, Clark, for the answer. Richard Mommersteeg, who is a member of our new community council, asked about capacity of our inpatient beds, and Naomi answered that by saying capacity is almost always at 100%, which sitting here at South Bruce Gray Health Center, we know as we try and access those Schedule I beds, those acute mental health beds at Owen Sound. So it is a challenge, and not only in our own community, but many communities across Southwestern Ontario. And we'll just switch gears. Some good questions about geriatric outreach for mental health. So Kathy Smith is asking, I see we have geriatric inpatient service. Are there any geriatric outreach mental health and addiction services for older adults in Grey-Bruce? Who'd like to tackle that one?
I did answer a little bit on the in the chat box. We've working, and I see Lauren's there, and we've been working with Lauren on the senior strategy. And so there's not a specifically mental health services tag to that. We have one outpatient case manager at the hospital that we've really kind of siphoned from our other case management services to focus on geriatric, because that is a population. The dementia population is served by our Behavioral Support Ontario team. We have a geriatric psychiatrist coming out of UHN in 2 days a month, and then we have the new geriatrician, Dr. Ahmad. And so we've really been working quite closely with the senior strategy to streamline all of the referrals that come in. Lauren, I don't know if you want to add more there.
Sure, yeah. I have to say, my name is Lauren Gardner, by the way. I'm a nurse practitioner with the Southwest Frail Senior Strategy, working specifically within the Grey-Bruce subregion. I'm really happy to see this question, because I will say we have recognized this as a gap. Supports for older adult mental health has been certainly something that's been on our radar. We have been kind of pulling together the different teams to kind of see who potentially has some capacity. As we say, everybody's mentioned capacity today, and just in terms of skilled human resources. This is a very kind of niche skilled area to be able to work with patients that perhaps have some cognitive change, but even if they don't, in the setting of supporting an older adult with a mental health concern, we need kind of the intersection of being able to support older adult and that mental health lens. So we're actually working on at the Southwest Frail Senior table, we've been looking at how can we offer some educational resources to the existing mental health support workers that are already doing such great work, that perhaps could just use a little boost in their knowledge of how to support specific issues that come up in kind of older adult side of things. So again, as we look to do some priority planning with the OHT table, perhaps there will be some opportunity to leverage some resources that already exist and just give a little bit of that boost from an educational standpoint. In terms of, yes, as Naomi mentioned, we do have some new geriatrician to the area, which is really, really exciting. And I think within the program at GBHS and the opportunity to build out from there, there will be more and more resources specifically geared toward older adult mental health. So thanks for asking that question.
Thanks for the question, Kathy, and for Lauren and Naomi for answering. We've got about 5 minutes left. I want to make sure Alex has a good chance to wrap things up and summarize tonight and then talk about our next session coming up. A few questions here, and if we don't get to all these questions, we'll try and provide those answers in a follow-up slide, as I said, which we'll post to our website. Question from Kathy again about stigma. Given that individuals with more complex mental health addiction issues can face stigma, what's the OHT's approach around addressing stigma? So I'm not sure if we've got the answer what the OHT is, but love to hear from Clark or Phil or Naomi about this.
Well, you know, for community mental health, it really is about transforming community, and you know, there's no CMHA tagline to say the caring community is the answer. So really, it is trying to integrate people at every opportunity where we can with mainstream and take away the fear. I think as well, more and more people talk about mental illness, the more normalized it becomes, and it really is it touches everyone. 1 in 5 Canadians will experience mental illness each year. So that's not a static number, that changes from year to year. So 1 in 5, you know, of this group could be this year, and then a different 1 in 5 of the same group could be next year. So over lifespan, either as an individual yourself or a family member, I'm sure everybody is touched by mental illness or addiction. So it's really a continual dialogue. We have been making some gains over the past number of years as more high-profile people come out, more you know, professional people come out and break that stigma, I think, and perception that it's only you know, homeless people and things or have lived with a mental illness or an addiction. So it's an ongoing conversation. I think the OHT gives us a platform to work more closely together. It gives us an opportunity to educate each other across sectors to get a deeper understanding of what the challenges are and how we can help each other across those sectors address some of our issues as well. So I think that's more broadly what I see OHT value and OHT can provide.
Thanks, Clark. So we've got a couple of minutes left here. A couple more questions here that we'll try and address as a follow-up. Some around virtual care, access to family physician offices, so we can address those. And thanks, Bill, for providing the additional comments about the improving broadband service. I'm going to pass it over to Alex and let him summarize tonight and then talk about our next session, which will be coming up in a few weeks.
Thanks, Mike. And yeah, thanks everybody for great questions, a high degree of interest, very popular topic, top of mind for everybody attending tonight, and I think others that perhaps were not able to attend. So I want to conduct a very quick poll to give us a bit of feedback to help us in terms of this session. If we can, there's 2 questions to answer. So we want to get a sense of outreach. Did you participate in the first session back in June? And the second is, how has this session helped in terms of increasing your understanding of healthcare? So if you could just take a real quick moment and answer the poll. And Jen, I believe that's up in front of everybody, correct?
Yes, it should be.
All right, great, thank you. So let me know, Jen, when we're close to done there, and then I'll do a wrap up.
Sure, we have about 32 people responded. There's 43 in the room, so I can close it off. Give everyone about 3 seconds and then I'll close it.
Okay, great. Thank you. Okay, so about 60-40 in terms of attended the previous session. So that means that we're expanding our reach here, larger audience. Large percentage, it has increased, some strongly and some in agreement. So that's good. Very helpful for us as we structure our next session. I think from me, the takeaway is that the direction that we're going in as an OHT is very much the right direction. We've got a lot of issues and challenges to solve in order to provide better healthcare to the population in Grey-Bruce, and there's a high degree of interest in doing that. And there is a strong sense of urgency and need for change. And it will be really important as our OHT forms is to consider that perspective as we establish our strategies and determine our priorities going forward, which will be done in a very, very consultative way. There's lots to do here, and I know that speaking on behalf of my colleagues in all the health service provider organizations across Grey-Bruce, we share the desire for change, and we share that sense of urgency. But we need to be very thoughtful and considerate in terms of how we do it, because we don't want to make it worse. We want to make it better. So from that perspective, thank you for your points of view. And as I said earlier, and Mike has reinforced, we will get answers to the questions that have not been answered out to everyone as soon as possible. And our next session, we don't have an exact time frame set for this yet, but I would imagine we'll have one, hopefully, and I don't want to make any commitments and get people mad at me, but given the high degree of interest and the sense of urgency here, I'm hoping that we'll be able to get another session put on, towards the end of October or into November, depending on our ability to get organized. As Mike has mentioned, we all have our full-time jobs, and these are our volunteer jobs, and we all share a passion for reforming the healthcare system, and we'll do our best to get something going towards the end of August or end of October with that same sense of urgency that everyone in the audience has. So I just want to say again, a big thank you on behalf of the entire OHT team and all my health service provider colleagues across Grey-Bruce. Thank you for your attendance, your interest, and your support. And we're really looking forward to meeting again, and even more importantly, beginning to discuss some system-wide changes that we can affect to start improving things for our population. So thank you very much, everybody, and have a great evening, and we'll talk again soon. Bye-bye.